So cool. Welcome to the first journal club of the semester. This is the fourth journal club overall. That's why it's called number four. I'm gonna be presenting on the topic today. If you already haven't, please go check out the paper that was shared off. The link. I can send you guys the link again, but it should be in your email. And then I'll put this in the chat. So that's the article we're gonna go over. But for your points, that's the QR code. If you want to scan it, password is AFib. Cool. That's enough time for that. So, what's the journal club supposed to be? Since this is the first one, we're gonna go over what's a journal club. So the journal club's purpose is to introduce you to published literature. So this literature specifically is published in the journal of the New England Journal of Medicine. And yeah, there's several different journals, but we're going to focus on published literature. Often that means it's peer reviewed, so it's highly creditable. And it's going to give you exposure to hopefully a low stress learning environment where you could be comfortable with literature, know how to read it, know how to analyze it, and make some conclusions off of it. It'll also provide you a space for practicing how to present research. Presenting research is something that's often intimidating to some. So yeah, giving you a forum to practice it to where we're all learning it's a great opportunity. And we're also going to expose you to different areas of academia. Most of the time in this journal club, it's going to be healthcare focused or clinical trials or something. But if you want to do something that's tangentially related, maybe psychology research, or it's biostats or epidemiology, or stuff like that, those are also welcome as well if you want to do that, those presentations. While you're participating, these are the expectations. You should have read the article. Bring up your own ideas. If you have any questions or maybe in addition to the research, bring it up. Question the methodologies, discuss applications. How can this be used in the future of patient care for this one specifically? Practice reading the literature. You're going to be reading a lot of articles within the journal club. Want to identify common structures to research papers. So often they'll have similar sections, and take notes and annotate if needed. It helps you get in the habit. But without further ado, let's get into it. So, rivaroxaban in rheumatic heart disease and associated atrial fibrillation. It's a lot of words. That's the article for today. Let's get into what this all means. So a little bit of the background. Rheumatic heart disease is a disease that leads to damage in the heart valves resulting from a rheumatic fever. And this rheumatic fever is from strep throat. So streptococcus. I forgot if I put the so streptococcal pharyngitis. I don't think I put the actual strain of strep on there, but it's an autoimmune reaction, and it can lead to damage to the heart valves. But this can be prevented if you just treat strep out as it is, take antibiotics, have supportive therapies. Rheumatic heart disease is often mitigated. So when you don't have access to these healthcare interventions, this can progress into rheumatic heart disease, and predominantly low middle income countries. And this disease kills just over 280, almost 290,000 people a year. Atrial fibrillation is the arrhythmia of the atria. The atria is again where it's the smaller chamber in the heart. So remember, atria, then it goes into ventricles. Ventricles are the big ones that do all the major pumping. But atrial fibrillation, it's when your atria doesn't pump down. It kind of just wiggles in place and doesn't perform effective pumping. So normally you want to have effective pumping down into the ventricles where you want it to drain effectively into the ventricles. And while it's like wiggling up there, it might lead to unneeded coagulation. The blood's not going where it needs to be, so you want it to effectively pump. And sometimes that's caused by weakening of the muscle. Maybe electrical activities aren't performing as well. But in either case, it's an arrhythmia, so it's not normal rhythm. So AFib is frequent in patients with rheumatic heart disease because of the rheumatic mitral stenosis. Now, the mitral valve is the heart valve that connects the left atrium, left ventricle, and this mitral stenosis being the narrowing of the valve, is because of the pressure overload is resulting from the rheumatic fever. The valve will be affected. It'll be inflamed, it'll be damaged, and then all this damage makes the valve stenotic, or it shrinks the valve. And you don't want that valve to be shrunken. You want blood to flow through it. And when this is backed up or this is shrunken, you'll get pressure overload. So if you have, if you don't allow fluid to go through something, they'll back up pressure, and that pressure will lead to the damage. And usually that'll lead to damage around the atria in this case, and then you'll have this atrial fibrillation. Any questions on that? All right, a little bit more background. Rivaroxaban, also known as Xarelto, is a blood thinner. So if you're not familiar with the coagulation cascade, there's several different factors that go on the coagulation cascade. Factor 10 is the intersect between the intrinsic, extrinsic pathways. And this Xarelto is going to be the it's the inhibitor of factor 10A. It also affects prothrombinase, or that's the enzyme that converts factor 2 prothrombin to factor 2A, which is thrombin. So those are pathways of the coagulation cascade. And this helps your blood clot. So all this, there's about, I forgot, 13, 14, there's always more being discovered, but there's several factors that help your blood clot effectively in your body, but also that can lead to some problems when you have unwanted clotting. There's also a couple of factors. I won't go into all this. If you want to look up the coagulation cascade, there's several different videos. I know osmosis.org does a great explanation on the coagulation cascade, but you want to focus on what vitamin K dependent factors are. So this is 2, thrombin, 7, 9, and 10. So those are the factors that you want to focus on. And why that's important is warfarin, also known as Coumadin. It's a factor K dependent factor antagonist. So it's going to prevent all the factor K dependent factors from working properly, and that's what makes it an effective blood thinner, because it doesn't allow this clotting. Some other measures that they use in the paper, stroke. And because this is blood clotting, is likely ischemic stroke, or ischemic being it's blockage, and then there's dying tissue around in the brain. Systemic embolism, the likelihood of death, or the most likely symptom being a pulmonary edema, or PE, and that's when you get a clot lodged into your lung vasculature. And there's also a chance for you to experience sudden death from this systemic embolism, where this blood clot, it'll get stuck in the pulmonary artery and you'll die. So that's never good. And but PE is probably the most common that you'll find. Also, myocardial infarction, you'll see a lot of clotting. It'll clot, be pumped out, and then it would go into your coronary vessels, where it will clot around the heart, and it'll lead to the myocardial infarction. They use an awesome scoring system. I'm not gonna pretend. I'm not gonna go through the pronunciation of this, but it determines your risk factors for. This is the measure of the risk factors in the paper. But if you want to go through this, each risk adds a couple points, 1 or 2 points, and that's how they determine risk for. And they only use the interventions, so these anticoagulants, after you reach a score of 2. Some other things, creatinine clearance. This is the marker of how much vitamin K that they use. So creatinine clearance is a marker for renal function. So your amino acids, and the production of the amino acids produces creatinine as a byproduct. Your body naturally releases creatinine through the urine. So creatinine clearance is the marker for how they did the vitamin K calculations. INR, or this is the prothrombin time ratio. I should have written the actual acronym name, but it's a ratio of the abnormal, or the measured prothrombin time versus the real prothrombin time. And that's how they determine the amount of clotting that the patient's going to experience. So what was the hypothesis in the paper? So I'm just going to say Xarelto. I cannot pronounce this word. So they said Xarelto therapy would be better, will lead to better outcomes than vitamin K antagonist by itself. So the vitamin K antagonist was kind of like their control, because they don't want, with these types of studies, they don't want to not treat the patient. So the already understood baseline was using vitamin K antagonists, and they're comparing the vitamin K antagonist patient population to the new variable, which is the Xarelto. So they wanted to see which ones work better. How they recruit these patients. So they recruited 4,500 people, primarily female. This is the reason why they recruited primarily female. A lot of the patients that suffer from RHF, RHD, sorry, rheumatic heart disease disorder, primarily female. So there's a lot of females that experience this. The average patient population, they had that score of less than 2. And remember, they started interventions at a score of 2. Mitral valve stenosis, 81% or 82% about. Important again, because this mitral valve stenosis leads to atrial fibrillation, and that's where you there's the introduction of the risk of blood clotting. Lots of patients. What was interesting is that a lot of patients have already received a previous vitamin K antagonist. So about half the patients have already received that before. Raises a couple of questions, right? Does the body so adapt to this? Is it used to having this type of anticoagulant? Does this new factor 10A inhibitor mess with that? So there's a couple of questions there. A lot of patients have taken beta blockers for the heart disease. Beta blockers are a common intervention for arrhythmias, and a lot of patients take diuretics. I couldn't find a reason for that, but that's kind of a cool statistic to know. I'm thinking maybe right heart failure. You can read about how right heart failure leads to a lot of edema around the around the extremities, but that might be a reason. I'm not too sure. And so let's get into the results. So the results that they found is that what they measured was cumulative incidence, and cumulative incidence, I believe it was, let me pull this paper, it was stroke, death, and myocardial infarction was going to be the cumulative incidence. And they kind of pulled that up together to percentage of the patient population. And yeah, let's see. Yeah, stroke, systemic embolism, myocardial infarction, and death for vascular unknown causes. And what they found is that there's a higher cumulative incidence among the Xarelto group versus just the vitamin K antagonists. So the vitamin K antagonists, there's less incidence, which was the primary conclusion of the study, saying that Xarelto was worse in terms of treating for rheumatic heart disease. Yeah, so that was the primary graph. Some other cool graphs that they explored was stroke or systemic embolism was higher in the Xarelto group. However, if you see the scaling, they don't use the same scaling every single graph. The big graph is going to be the 100 scale, and then they narrow it down to where you can visualize the data better. it's a really small scale. So they said that it might be up to the chance. Um, yeah, it might be up to chance, and then death was was right on par with a cumulative incidence. Cool. That's it for the paper. Does anybody have any questions about um, what the paper is about? Uh, Anybody want to discuss anything about any of the methods that they use, about anything that they found? This is a pretty straightforward paper. It's a really good introductory paper to see. It's basically an apples to apples to see. Okay, we have this one blood thinner, another blood thinner, but we have an overall disease that we're going to try to treat. What's more effective? Um, but yeah, pretty straightforward paper. Does anybody have any questions? Okay, cool. That was straightforward. We got through that in 20 minutes. Okay, so now we have to get to the actual interactive part. This is the ethics portion. So a common feedback from last year's journal club was we should introduce ethics. There's a lot of different changes happening in healthcare and the healthcare field, and understanding ethics, understanding common scenarios, and understanding um, how to navigate those and address those properly. It's a really important part of being in healthcare. So we'll introduce one of the ethical principles today. The ethical principle today that we're going to introduce is patient autonomy. So does anybody have an idea of what patient autonomy already is? Can everybody see my screen for this? Hope you can. Sick. Yeah. Anybody want to take a stab at what patient autonomy is? All right. Quiet crowd today. So, what patient autonomy is expressing respect for patient autonomy, means acknowledging the patients who have the decision-making capacity have the right to make decisions regarding their care, even when their decisions contradict clinician recommendations. So, this is patient independence. The patient has the final say. You can't force treatment on anybody. So, uh, even you can try to convince them, but if they give their decision, that's their final decision. And patient autonomy is an important ethical principles because um, it introduces a lot of conflicting scenarios. What if a patient has there's a treatment available that can help them better, but they still refuse it? Or yeah, there's a lot of new medical interventions that some people are really cautious about, and they're scared. But and no matter how much data you throw at them, they're not going to be convinced. And that's okay. That their feelings of being scared are valid. So patient autonomy is, you can't really force anybody to take a treatment, um, even if the clinician recommends it. So if you're the physician or you're the PA on this case, and then there's some scenarios that I think are good scenarios. They're really common ones that you'll see in graduate school. So I wanted to go through just two of them. Um, so the first scenario, you guys can read through that. Uh, so I'll read it out loud anyway. So a woman enters the emergency room with stomach pain. She undergoes a CT scan and is diagnosed with an abdominal aortic aneurysm, a weakening in the wall of the aorta, which causes it to stretch and bulge. Uh, the physicians inform her that the only way to fix the problem is surgically, and that the chances of survival are about 50-50. They also inform her that the time is of the essence, and that should the aneurysm burst, she'll be dead in a few short minutes. The woman is a model, and she worries that the surgery will leave a scar that will negatively affect her work. Therefore, she refuses any surgical treatment. Even after much pressuring from the physicians, she adamantly refuses surgery. Feeling that the woman is not in her correct state of mind and knowing that the time is of the essence, surgeons decide to perform the procedure without her consent. They anesthetize her and surgically repair the aneurysm, and she survives and sues the hospital for millions of dollars. Do you guys think this is correct? There's multiple perspectives on what on how to approach this scenario, but I want to ask you guys, what do you think the woman feels? What do you think the woman is thinking at this time, and is her decision valid?
I think that although she did refuse, and it ultimately is her decision, uh, I guess she's technically in the right to sue if she wants, because, like you explained, of patient autonomy. Um, she's well within her right to sue because, well, she refused treatment and they did give it to her. They did give it to her anyway.
Yeah, definitely. Right. It wasn't, she didn't sign anything saying it was under her consent. She didn't consent to the procedure. So it's valid to sue. You don't want anybody to do anything to you without your consent. Yeah, good answer. But that's the woman's perspective, right? Do any of you think that the physician's actions are justified in any way?
I think the physician's I guess actions are justified in some sort of way because it was considered an emergency situation. Like you said, time was at the essence, so it was really just deciding on an emergency factor, and part of it could be that while she did not initially consent to the treatment, being that it was an emergency, that could be considered the right way, I guess, to handle the situation.
Right. Yeah. And yeah, the emergency, they don't want their patient that they care for to die. We'll go over another ethical principle later on in other journal clubs about beneficence. That you should always act in the patient's best interest, or should act in a way that would only benefit the patient. And this might be a scenario where beneficence, in their mind, may have overpowered the principle of ethical of patient autonomy. So yeah, that is a perspective of the physician. And is, there's this approach where they really just uh, uh, um, perform the procedure without her consent. And is there anything else they should have done? Another approach they should have taken?
I think maybe further explain the chances of survival being 50-50 and try to convince her that, like, her, I guess, according to her, her modeling career might be affected because of the surgery, but without surgery, she'd have no career or life either. So maybe explain the risks a little bit more carefully and give her some more time to think, even though, like, it has to be completed immediately at the surgery, but maybe just give her a chance to think about it.
Definitely, yeah. And 50-50, giving her more education, really sitting her down. Yeah, those are great points. Um, Now, besides this scenario, obviously this is somewhat a complex scenario. Is there any scenario that you can think that's right to take away somebody's autonomy? That maybe a court order would be justified, make this ethical. Is there any way? Is there any scenario that you can think of for that?
Perhaps if she was not of sound mind, if they could prove that her decisions are not sound, like she is in a mentally unstable condition, perhaps through stress or a psychotic break because of her condition.
Yeah, definitely. A lot of states put psych holds on patients. The state or the statute or the law that's varies state by state, but then across the board is normally a psych hold for 72 hours. And that's a form of taking away a patient's autonomy, right? They can't. Normally, they wish to do harm to themselves or others, and a hospital can take away their autonomy to keep them or others safe in that situation, and that's perfectly legal. And the consensus is that taking away the patient's autonomy at that point is ethical. So yeah, definitely. If not a sound of mind, or if they're not considering scenarios, or if they're not considering things rationally, this might have been justified, and this might have been ethical. Cool. Yeah, great discussion. A little bit of a side note. Cutting into somebody for a AAA is one is one of the interventions. However, in recent years there's been developments in endovascular treatments for AAAs, or abdominal aortic aneurysms, where they can go into your femoral artery. So that's an alternative that some patients may be qualified for, and it leaves somewhat smaller of a scar, and only in the leg. So that's kind of a cool side note. So thanks everybody for your participation on scenario 1. One more scenario for today. So I'll let you read that while I read it aloud. So a woman was diagnosed with motor neuron disease 5 years ago. This is a condition that destroys the motor nerves, making control of the movement impossible, while the mind is virtually unaffected. People with motor neuron disease normally die within 4 years of diagnosis from suffocation due to inability for the respiratory muscles to contract. The woman's condition has steeply declined. She is not expected to live through the month and is worried about the pain she will face in her final hours. And she asked the doctor to give her morphine for the pain if she begins to suffocate or choke. This will lessen her pain, but also hasten her death. And about a week later, she falls very ill and having trouble breathing. Now, the question that I have for all of you, this is a case of, we're introducing a concept called euthanasia. And is this correct for her to ask for this treatment, to ask for these drugs? Does she have the right to make this choice, especially since she's about to die soon? And another case of patient autonomy, does she have the right to request this and push for this? And is this an extension of her patient autonomy?
I think it is. I think she should be able to advocate for, like, even though the death will be hastened, it'll be faster and it'll be like maybe less painful. So I think it's well within her rights to be able to request morphine for pain.
Definitely, yeah, and that's her perspective, right? So considering her perspective, this is going to be painful. This might be more drawn out, but having it be less painful and faster might be better for her. But now considering her perspective, now consider the healthcare perspective. There's a physician, there's a human that has to make this decision to give somebody a drug that might kill them faster. Is there what would, if you were in that position, would you feel okay about this? Because again, I introduced the concept of beneficence, only doing something that's better for the patient. Is this an example of beneficence?
I believe it is, because her condition is terminal, which, as we all know, means that we cannot rebound from it. It's not curable. And in such a case, the point of the physician should be to lessen the pain as much as possible, especially if the patient has the free will, which, according to the scenario, she has a sound mind, can choose to do so.
Gotcha. Yeah, definitely. And now we say in this scenario that she's not expected to live through the month. But is the amount of time that they're stating in the scenario, is that ethically relevant? What if instead of a month, it'd be a year, 2 years? And where do you think you would draw the line on this? Should there be a distinction, or should the patient have that choice at the moment of diagnosis?
I believe that the patient should have the choice if they are of sound mind whenever they choose, especially because we have a similar process with DNRs or do not resuscitate forms, where it could be years before that form ever comes into effect, but they made the choice when of sound mind to sign such a thing. And during any case in her diagnosis, as long as she has mental capacity to comply with that, she should be allowed to. Perhaps maybe she should have someone who could witness her decision to prove that she is of sound mind. They could verify it along with another physician signing off on it as well. But if she is of sound mind, I believe that she should be allowed to make her own medical decision, even if it's uh, further out.
Gotcha. Yeah. Um, yeah. Another question for you guys. Another ethical principle that we'll bring up is non-maleficence or do no harm. And a lot of healthcare workers, they don't want to do any harm as part of their part of their oath to do no harm and not hurt anybody. But if you were the physician in this scenario, would you pass the patient off to another doctor? And does that free you from ethical obligations with this patient, knowing that that doctor may or may not provide her with the treatment that she desires?
I don't think that necessarily giving the patient off to another doctor is freeing you of ethical obligations. You are passing them off, but you're still, in a sense, you know about the case, and you may be, in fact, working with a team with these doctors. And so, being that part of a team, you're still in that collaborative sense, but maybe you're just not necessarily directly making all the procedures, but in a sense you're still aware of the case, you're still there, and you still can consult on the case indirectly, so therefore it doesn't free you from those obligations.
Gotcha. Yeah, thanks for your perspective on that. Does anybody else have an answer or want to chime in or give their thoughts?
My personal opinion on it is when we sign the Hippocratic Oath that says do no harm, that refers to taking action that is not necessarily in the best interest of the patient. In this case, lessening her pain with a terminal illness isn't committing harm for the patient, even if it does hasten her death a little bit, because it is actually lessening her pain, therefore lessening the harm already being inflicted upon her.
Gotcha. Yeah, thanks for that perspective as well. But yeah, that's all I have for the ethics presentation today. Thanks for having these conversations with me. I really appreciate all of your feedback. It's great to hear what you all think about these types of scenarios. It's cool, and I hope that this could be a mainstay in our journal clubs for the rest of the semester. But I won't be doing the presentation for Journal Club every single week or every single month. I'm hoping that one of you could take over as the presenters, and there are several students that have also expressed interest in presenting. So I'll reach out to whoever is interested. If you don't already have the Journal Club mailing list, that'll be sent out later. But yeah, if you're interested in presenting, we'll present an article, and then I'll tell you which ethical principle you're going to present on, and you can do that. And I'll be here to mentor you, help you through the presentation. So if you guys are interested in that, definitely reach out to me, and we'll work on it. But that's it for today. I'll give you 23 minutes back, and yeah, I'll stay behind if anybody has any questions. But thanks so much for joining.
I had a question. I joined a little late. Was there a sort of attendance form that I had to sign or anything?
Yeah.
Or
And the password to that is AFib.
sorry, could you repeat that?
AFib.
Oh, okay.
All. Yeah.
All right. Thank you.
Of course.